Hello, everyone. If you don't know me, I'm Troy McKenzie, and this is a teaching module in partial fulfillment for my ODU course. It's Nursing 402, Role Development for the Nurse Educator. So my project is based on kangaroo care, also known as skin to skin in the neonatal or newborn intensive care unit, referred to as the NICU. So briefly, I just want to talk about what kangaroo care is. Kangaroo care is a type of therapy, and it benefits both the parent and the infant. It is used in NICUs all over to improve not only the bond between the infants and parents, but also to improve the physical health and overall development of the infant that's in the intensive care unit. Oftentimes, those babies are rushed from the mother directly to the NICU, and the bond that is usually created with a healthy newborn is broken and it's not developed as much as it should be. And um, that can wreak havoc on so many different angles of development, physically, mentally, emotionally, of everyone involved, especially the newborn. So, but kangaroo care is exactly what you think it is. It is basically skin to skin care. It is when the newborn is unclothed. They usually just have on a diaper placed on the unclothed chest of a parent. It does not have to be the mom, it can be the dad. Um, and I've also done it for grandmothers and siblings. So it's not you you can't make it just about mom or make it just about the baby all the time. So just to let you know, studies have shown that kangaroo care should typically be performed at least once a day with either parent, and the guideline is typically to be at least 60 minutes. Um, where I worked, the average is somewhere between 2 to 3 times weekly. Of course, there's some outliers that some of them get to do it every day and some of them don't do it for days on end. It's just, one of those things that's not really regulated. It's not mandated, so it's hard to enforce it sometimes. It is a section on the electronic documentation system when it comes to kangaroo care. It's like a little checkbox. Did you do kangaroo care? And you check yes or no. But that's just about the only accountability that there is for it in my hospital. So why is this? There are some barriers to kangaroo care. There is limited time in the hospital, limited staff, being overloaded. There are fears and anxieties of parents as well as on the side of the healthcare professional. And there is an overall lack of education on the topic. So my presentation aims to close the gap between what is known and what is still to be learned among the medical staff in the NICU with respect to kangaroo care. Okay, so my cognitive knowledge objective for this particular project was upon completion of this presentation, the NICU nurse will be able to identify patients and families that will benefit from kangaroo care according to evidence-based practice guidelines agreed upon by the unit and some checklist with 100% accuracy. Now, I say that because the checklist isn't standardized across NICUs in my area, in the state, or across the nation. It's just one of those things that's individualized to each particular unit. Um, there does seem to, however, be a universal consensus and a general group of standards that we used as a guideline to start, maintain, and conclude the kangaroo care. There is a checklist where I work, but it's not hospital sanctioned policy, excuse me, just simply like a checklist made by and amended by the experienced nurses, the medical directors, with some input from some of the neonatologists, evidence-based practices, respiratory therapists, and even the physical therapists. We do have a dedicated physical therapist on the unit. And this list is typically shared with new hires and incorporated into the new hire orientation program. It's like a notebook, and Kangaroo Care is probably like 2 pages out of 150 pages that you receive. So for the purpose of this checklist, for the purpose of this presentation, this checklist will sort of be the gold standard to check accuracy with the learning and dissemination of vital information. So knowledge objective. The meaning of skin-to-skin contact without clothing between an infant and a parent. The ideal candidates include all NICU infants that do not. So just a moment with that, just keep in mind that sick infants typically decline rather suddenly and rapidly. So while some of these contraindications may not sound as if they disqualify an infant, I've seen infants suffer major blows to their overall health over something as simple as bath time. Active umbilical catheters. Umbilical catheter is a central line inserted through the artery and or vein found within the umbilical cord after delivery and the cord is cut. Require vasopressor therapy. This is for infants that don't have stable blood pressures and they are on vasopressor therapy as far as IVs are concerned. Have a dependence on oxygen hood therapy. Show negative responses to stimulation. We know that infants respond differently to the environment than from an adult. Where we use our subconscious and our judgment to filter out things we don't need, infants don't have that ability. So every sound, touch, smell, exposure to lights, and even taste can distract them and even cause them to burn calories to process their environment. Negative responses to stimulation could be desatting, bradycardia, tachycardia, even apneic spells. While signs of overstimulation can include yawning, sneezing, shivering, startle responses, frowning, flailing, extremities, or crying, in addition to those negative responses that I just mentioned. Sometimes when they require more than one phototherapy light, and when they require an increased amount of thermal regulatory support. Implications include improving emotional health, developing mental health, aiding in social health by facilitating attachment and bonding, and improving physical health of infant by regulating temperature, heart rate, and the immune system. Some risks are that we are all worried about whenever we do kangaroo care. Accidental removal, displacement of lines, that includes IVs, feeding tubes, suction, Foley calves, even ETTs, endotracheal tubes, and other oxygen support. And we also worry about physical bodily harm by poor positioning, bumping, or even dropping of an infant. So methods, materials, and time that we use. So we're going to definitely use a lecture and delivered via the computer, conference room hall, or just a quiet spot where you can listen, and computer access to actually play the recording. It shouldn't take 30 minutes, but I've allotted 30 minutes. Anywhere from 15 to 30 minutes to finish this. Psychomotor and skills objective. So upon completion of this presentation, the NICU nurse will perform a return demonstration of correct positioning and handling to be checked off by an experienced NICU healthcare professional and/or mentor. So the psychomotor and skills objective covers a few points. The first one is observation of experienced healthcare professional. With kangaroo care, you can learn, you can read, you can observe, till you're blue in the face, but you actually have to see it being done with an infant, then you have to actually respond in turn and do it yourself. You learn by doing in this particular skill because it takes some finesse to know if the baby is in a good position, if the parents are in a good position, and that's just something that you have to practice over and over. Now, for the purpose of this particular training, I have listed that a simulator doll can be used. Those are hard to come by. There's one or two located on my particular unit, but those are hard to come by, and you can't just go pick it up at any time of the day or night. You have to sign it out. You have to, go through a whole list of things in order to be able to work with it, only because it's a very expensive piece of equipment. The multidisciplinary involvement of kangaroo care facilitation. Now, it's not just the NICU nurse. Most of the time, if it is a really sick baby, you want to have at least 2 people there in order to help initiate kangaroo care. That could be 2 NICU RNs, it could be a respiratory therapist, it could be a neonatologist, and it could be the physical therapist. There are a few people on the unit that are willing to help you because you need that extra pair of hands to guide not only the baby and the parent, but the lines of support and other equipment. When we're talking about application and positioning, which does involve recognizing hazards and risks that prevent kangaroo care, including parental issues. There are some times where it is not the infant's state or status that is preventing kangaroo care. Sometimes it's the parents. If the parents have an infection or some other disease, maybe a physical handicap could be a barrier. So there's many other things outside of the baby's, health that can affect that. Parental and infant preparation prior to transferring. Now, preparation will include securing lines of support for both the mom and baby, because sometimes mom is still in-house and sometimes mom has her own set of IVs and lines, and that can be a disaster waiting to happen, especially when you have feeding lines, you have babies' lines of support, you have babies' oxygen. It's just, and then you have leads going to the monitor for the baby. It's just a lot. Transfer techniques. Well, it's just what it sounds like. How are we going to get this baby from point A to point B? What route are we going to take? Which side of the isolet's going to get opened? What is the mom going to wear? How is the mom going to receive the baby? On what side is she going to receive the baby? And then afterwards, the contact confirmation, making sure that baby is skin to skin with mom or dad or whomever, and making sure that they are snug as a bug and that the baby is secure and safe. So some of the medical equipment that I've already talked about, and maneuvering around, but I've already talked about it, is the oxygen lines, umbilical, peripheral, interosseous lines, monitor leads, and any physical therapy, OT, ST modifications for infant that may be needed. The return demonstration by learner and evaluation by experienced neonatal professional. So for method, materials, and time, for this particular objective, we're going to really focus on the demonstration by the instructor or experienced RN and the return demonstration by the learner. The materials we need are usually going to be the checklist for the nurse prior to the initiation of KC, infant and parents present for demonstration, or if we're just learning and we feel more comfortable with it, we can have the NICU simulator doll for return demonstration, and so the medical equipment that usually will come with having a NICU infant. Oxygen lines, IV lines, nasal gastric tubes, all of that good stuff. And approximately 10 to 30 minutes. I say 30 minutes, worst case scenario, but typically this kind of training will only take about 10 to 15 minutes. So for the effective attitude objective, the learning NICU nurse will reflect on and be able to explain why instruction on kangaroo care to NICU families will foster effective bonds between parents and the infant while answering questions, engaging with, and alleviating parental fears and anxieties. This particular objective tends to be more about the thoughts and feelings by not only NICU families, but also by RNs and anybody in the NICU as far as healthcare providers. We want to discuss with the NICU family their perspectives on the process of initiating, sustaining, and culmination of kangaroo care. Just saying, some some families will have their preconceived notions on what kangaroo care is, who it is for, how you do it, how long you do it, and when you need to stop doing it, and what you do after you do it. So those types of things are addressed in this. Some of the common fears and misconceptions of the kangaroo care process. So some people believe that kangaroo care is more harmful to the baby. That is just being uneducated. Um, there's there's nothing to substantiate that other than there are every once in a while, like I said, there's an accident where a parent will drop a baby or a IV will be knocked out. We can replace an IV. We can put the nasal cannula back in. What we can't do is create a false bond because the parents refuse to be involved with kangaroo care. That's more harmful to the baby than an IV coming out. And and then the NICU RN's space and time. So there are some people that I've noticed as a NICU nurse that will stand back. They won't say much. They will stay out of the way and just wait until the NICU nurse actually says something and engages them. Well, this is your child, and I understand that sometimes we're like busy little bees around the room doing this, doing that. And of course, if someone is taking care of your baby, you don't want to get in their way and you want to keep them happy as well. But sometimes you just have to speak up and say, hey, while you're doing that, do you think we can participate in kangaroo care? Do you think I can skin to skin today? You know, just the NICU nurses need to really relay that, and a lot of them do. I can say that, especially the nurses that I've worked with. But that needs to be relayed more so that the parents are more comfortable with being in the space when the NICU nurse is there as well. Some of the common myths debunked: thermal regulation, that if the baby is out of the isolate or is not swaddled and on mom, then they're going to get too cold or something like that. That is not the case. Mom's body will help to regulate the temperature of the baby's body. So that's not a valid myth. Time needed for kangaroo care. Some people come in before work and they go, I just want to hold the baby in skin to skin for a few minutes before I go to work. Skin to skin kangaroo care is beneficial, and it's probably not going to disrupt the NICU infant as much if you do 20 to 30 minutes. However, you probably won't get the same benefits from it if you don't do it for a full hour. You need that full hour. So the kangaroo care versus skin to skin debate. Some people believe those two terms are the exact same, and some people have different definitions for those two terms. Kangaroo care, as we know it, is the chest to chest type of unclothed contact between a baby and a parent. That is beneficial for bonding and thermal regulation and boosting oxytocin levels. all of those good things. Now, I have heard some people refer to skin as an umbrella term to include things like bath time with parents, um, breastfeeding time, those kind of things, chest to belly type thing, like just, relaxing there with the baby laying on your belly. Yes, those are technically skin to skin, and that's why I've been trying to make sure I say kangaroo care versus skin to skin more often, just so people won't get confused. Emotional and mental barriers. Of course, there's always parental anxieties, fear of the infant being harmed, and the anxiety of developmental regression if you don't do it right, if you do it too long, if you don't do it long enough, those kind of things. Social barriers, lack of familial support, only because there are sometimes people in the family who believe that you should just let the baby lie. Just let the baby lay there, sleep there, don't touch the baby, let the nurse do the job and leave the baby in there. We'll touch the baby, we'll talk to the baby, we'll, pet the baby but don't pick the baby up. So sometimes that happens. And I've found that it's not cultural as far as that goes. It is just being uneducated or maybe too trusting of healthcare providers. Cultural beliefs and practices. I really haven't run into this, but it does seem that there are certain cultures that um, shy away from skin to skin care, especially if they have to be unclothed in front of someone, which you really don't. I mean, you have to get there, but it's not like you're going to be all completely naked. And there are some cultures who believe that um, messing with the sick baby will disrupt what's going on. I really haven't run into that, and my data doesn't really show any of those issues with as far as the needs survey. And my research is more geographical as far as cultural beliefs, so I don't know how much of that applies in the United States today. And then physical barriers, we talked about some of those parental health issues, and then some of those congenital deformities or genetic diseases that prevent kangaroo care. So for method, materials, and time for this particular objective, you have available formats, therapeutic communication, such as group discussions, simulations, role playing, and role modeling. For this particular project, we'll be doing um, a sort of a survey of the learning, but more so having the NICU RN verbalize that they will discuss these issues, fears, anxieties, myths with other nurses and families that they come in contact with. Materials needed as before is, the NICU, hospital room bed, the infant, or the simulator doll, or any documentation anywhere, and then anywhere in the hospital where the parents feel comfortable talking to the nurse or neonatologist or anybody involved in the baby's care. Just somewhere where they feel like they can speak without any prejudice or anything like that, which nowadays it's pretty common for it to be at the bedside, only because now we have individual rooms for each infant, which sometimes becomes not great when you have twins and triplets, because apart from a few areas on the NICU unit where there's like a bay room setting where you can fit two or three, when you have triplets or twins and they're in two separate rooms, it's kind of like more difficult to have those intimate conversations when one baby is not in the room. So. And that shouldn't take more than 10 to 15 minutes. And it's usually just daily instruction and constant reinforcement to the parents, having that communication between them and you, from the RNs, the neonatologist, the respiratory therapist, OT, PT, just having those lines of communication when you need it is you don't understand how far that will grow this bond between the family and the NICU baby. When you just have someone you feel like you can talk to and that they're giving you honest, truthful, genuine answers and tailored for your baby and not just necessarily a canned answer.